antioxidant effects.
I concur with Dr. Merrick.
Yeah, me too. Dr. Paul, what do you think about, if we measure like Dr. Peng has done, measuring like IL-6 or other, oxidative stress markers, capacity, will that be of any help clinical wise? And, I would suggest that we should treat the patients, not the labs. That's a common, everybody talks about it, but I don't know how many people actually practice it. So what I'm saying is that in real medicine, what if a patient with COVID-19 doesn't seem to, it seems to be improving, but the speed of improving may be slow. What if for those conditions we bump up the dosage? What do we think? Combining both clinical judgment along with laboratory, tests. We shouldn't be driven by lab markers.
Yeah, so we find the CLP to be exquisitely sensitive to anti-inflammatory therapy. So in most patients, it comes down. So I have a colleague now in Houston who has a severe COVID, who's giving him vitamin C and steroids, and paradoxically, the CLP is going up. We're not sure why this is happening. So this may be because of the pro-oxidant effect of the vitamin C. So what we're doing is decreasing the dose of vitamin C and increasing the dose of steroids. We really don't know, but I think that there is this concern. Some patients with COVID actually have a HLH kind of picture, hemophagocytics picture, and may require high doses of steroids. The CRP seems to be a really good marker, but I think we need to look at the pro and antioxidant balance to really know what we're doing.
Yeah.
How much of vitamin C he's getting, Dr. Merrick?
Yeah, what's a dose?
So we've been using 3 grams Q6.
No, but I'm talking about the person in Houston.
3 grams Q6.
Oh, okay, but the other thing is he in a respirator? He's getting oxygen?
Oh, yeah. So, yeah, these are really sick people. So we have a stepwise protocol. We believe you have to treat these people really early to mitigate the cytokine storm. So
because also the oxygen pressure could really push the vitamin C in order to be a pro-oxidant also. So you have to also be aware of that. What we're seeing, it's basically when you put people in the full throttle of the pressure, of oxygen pressure, they don't do as well. So they need the oxygen, but you have to be careful not to really enhance this cytokine storm and these free radicals pushing too much oxygen.
Yeah, so that's why our protocol, we actually use permissive hypoxemia. We allow the O2 sets to go down to 86 for multiple reasons. So we don't push the FiO2 quite, high.
Okay.
Hello, Dr. Mary. This is Cheng from Kansas. I want to ask you, when you give 3 grams to your patients, what's your infusion rate?
Yes, so we do it much like we did with our sepsis protocol. So we give 3 grams over about 20 minutes.
All right, thank you.
So so unlike Dr. Peng is getting a more continuous infusion, we're getting spikes.
Have you measured the plasma concentration of ascorbate?
So we did it with a 1.3 gram dose. Sorry, 1.5 gram dose. So with a 1.5 gram dose, we have troughs of about 2 to 400 and peaks of about 6 to 800 micromolar.
6 to 8 micromolar. Okay. Yeah, because that, just judged by that, in our previous experience, that concentration of ascorbate is not likely to generate much of peroxide. Just to speak.
Mm-hmm.
May I add a point here? Because I think in acute ARDS, they are already very scorbutic. So the dose, as a clinician, if you want to decide on a patient, leaving aside the lab test, my experience of treating dengue patients, dengue or chickenpox, the dose that actually helps them to feel better halfway through the infusion, even before the end of infusion, varies between 30 to 60 grams. Some patients will feel better with 30, 45, or 60. This is dengue or chickenpox, and within 2 days, there is full recovery and they don't need any hospital admissions. But ARDS is a severe sepsis, very severe acute sepsis. So from clinical point of view, I believe the dose of vitamin C has to be higher for more rapid healing. But of course, it's always the difficulty in getting the approval to use a higher dose.
So
Yeah, our experience is similar to yours, but they started feeling better at 50, and we had experience with chikungunya, mononucleosis, Zika, and influenza. But you know, here's a little bit different because with this enhanced cytokine storm, this physiological pathological process that damages lung tissue, it makes it a little bit more difficult. Because there's the issue also that if you give too much liquid, if you do more vitamin C, you're gonna have to put more liquid in, and that could be a problem also. And then having this oxygen being put in, it may change the pharmacokinetics and pharmacodynamics of vitamin C. So there's other aspects in this disease that may vary from the other viral disease that we have been treating. So that's why we have to pay attention what Dr. Merrick was saying in terms of we should measure and see what's going on, really.
The other thing that's really important that's completely missed, this is not ARDS. COVID does not cause ARDS. The ARDS that we see is caused by the ventilator. If you look at the lung water, or you look at lung compliance, or you look at the CT scan, this is not ARDS. It's a truly phenomenal thing. The patients get ARDS from ventilator-induced lung injury. So I think it's a terrible misconception that this is ARDS, because in fact, we try to prevent ventilating these patients. They do not have a PEEP or recruitable lung disease problem. They get it from the ventilator. So what we do is try and prevent intubating these people. This is not ARDS.
May I add something here? I think there are two issues here. Is that when we push, like Kay and others mentioned, when we give these pulse vitamin C high dose over a shorter period of time, the purpose there is to generate a pro-oxidant effect. But what if we use higher dose, but moreover continuous infusion at a lower level of plasma vitamin C level? This is primarily will be a mopping action of the of the free radicals in the blood, rather than in these pulse therapies for this. What do we think about that?
Yeah, there's one thing that vitamin C has like 10 different antiviral mechanisms, and I think they are, they don't go on all at the same time. So yeah. I think that's one of the issues. I think that antioxidant part, it's one of the first actions that vitamin C has. And then there are these secondary ones of enhancing antiviral proteins and providing energy and other stuff. I don't know if that answers the question. I don't think it does, but basically I'm bringing the aspect that vitamin C has all these antiviral mechanisms, and that may be important because it might be dose dependent. It might be even time dependent. And if the difference between giving a one big shot or giving it in a continuous dosing.
Yeah.
What about the effect of adding zinc to the mixture with vitamin C for a better cell penetration?
I'm sorry, can you repeat, because it was a little bit choppy early on. Can you repeat?
Yes. How about the fact that by adding zinc IV in the process together with IVC?
Mm-hmm. So zinc is fantastically interesting. So zinc itself inhibits the RNA polymerase of this COVID virus. It's been really shown this in vitro. And there are a number of zinc ionophores which actually increase intracellular zinc concentration, including chloroquine and quercetin. And so there may be some interaction between all these compounds. There's no question that zinc has specific anti-COVID properties apart from its effect on T cells. It actually inhibits directly the RNA polymerase of this virus.
So
The
what would
problem
be the
I think it's a pretty large molecule, so sometimes it's, I mean, it could circle around, but to get into the cell, it's going to need what Dr. Merrick said, some ionophore to really push it in and have it has its activity inside the cell also.
Yeah, actually, you know, not only zinc, vitamin C, you know, if we like to the integrative medicine approach, vitamin D and other antioxidants.
This is Patrick from the, could I ask Dr. Peng to repeat the results, because 50% survival on the IVC and 35 on the control, but you mentioned a subgroup. You mentioned something after that, and unfortunately, I couldn't quite hear it. So I wonder if you could just repeat the critical results that you have found.
Okay, so we also run the sub-analysis based on the people ratio. The people ratio is the quite low, it's less than 150, and also we can see the statistical differences regarding the survival. And I will see, because I just sent me the result. I haven't seen the details yet, and definitely I can share all the results and all my protocol with you.
Shishi.
Yeah. Yeah, again, you know, those who are interested, make sure you send me an email. I think you all have my email, and I try to dig this out of Dr. Peng's, you know, data. I mean, the data, you know, get them from him, and I will form my email group to further discussion here on this matter.
Yeah. So Richard, just to follow up on what Dr. Holford said, I think the subgroup analysis is really, really important.
Yeah.
As well as the change in IL-6. Because IL-6 and CRP are really important biomarkers. So if we could have the different trajectories of the change in IL-6 in the control group versus the treatment group, that would be pretty persuasive.
Mm-hmm. Dr. Merrick, I think you mentioned the ARDS being a side effect of the treatment. I think that's a very valid point. Oftentimes we may have manufactured some of these problems. So any other questions?
I have a quick question for the group. This is Asa from the US. I'm wondering if any of you have had any experience with vitamin C inhalation or nebulized vitamin C. As I've read some things online about doctors using this to increase the bronchial secretion vitamin C levels as an antioxidant method versus doing it IV vitamin C.
Anybody?
Are you sure it's not glutathione? I've never heard of vitamin. This is Misha Kogan, GW, US.
Hey, yeah.
Glutathione we use quite a lot.
Misha and Acer, I have
inhalatory.
had anecdotal experience with this in a cancer patient. And you have to be very careful that it's buffered. And it can be damaging over time. So I don't think this is the wisest thing to do in this setting. And I agree that nebulized glutathione may be helpful.
Let me add, this is
Yeah,
Deborah Davis.
That was my next question.
I was going to add that I think nebulized vitamin C is a terrible idea on its face. Buffering might be, it's hard to imagine. We spend all this time trying to keep people from inhaling acid aerosols. It's hard to imagine how this would make sense, frankly. But I also want to get back to the comment that Carrie made to, if everyone agrees that this is not ARDS, and there is that video from the New York physician that you all really should see, then what is this? It's really important that we name it, we give it the right name, because frankly, until this call, I thought it was ARDS. And if it's not, and there are these major differences in getting sufficient oxygen, and we may be killing more people with ECMO, that's what the implication of this is the pressure from the ECMOs could actually be harming people. Then I think it's very important for that information to be generated. So what do you want to call it, if not ARDS?
That you mentioned is actually what it seems to be happening, and that's true.
Professor Gattinoni from Italy, Germany, has actually written a few pieces on this is not typical ARDS, and I think it's published in the Lancet, and he looks at lung compliance and the shunt fraction. So for some bizarre reason, these people have really good lung compliance, but have profound shunt. So it seems to be a microvascular and vasoplegic disease. So there is some degree of lung injury, but they also have a profound microcirculatory and vasoplegic lesion. So what you actually call it, you know, who knows? It's not ARDS. It's probably better called COVID-induced lung injury.
May I suggest, you know, ARDS or not, the key underlying pathology is the exuberant oxidative stress. Do we agree on this? And a lot of the clinical consequences, whether it's ARDS, acute lung injury, microcirculation, angiopathy, and eventually death, the common non-specific pathway or mechanism is the increased oxidative stress. And that's what we are doing, what we're trying to treat with vitamin C or other antioxidants. Do we agree on this? If we agree on this, it doesn't matter whether it's ARDS or not, to me.
Well, the other thing is that there's, other than the damage to the lungs, there's damage, vascular damage, and there's damage to the red blood cell.
Yeah.
So you're having a triple problem here. You're having a problem of delivery of oxygen, of getting the oxygen, and the lack of area to receive that oxygen. So it's a triple problem. That's why I think the most important thing for us would be try people not to get to that level of you know, of complexity of the disease, trying to prevent this this physiological pathological cascade of the cytokine storm.
Based on what is being said, then isn't it convenient to add to the therapy ozone therapy? And I believe in Wuhan they were using rectal insufflation every other day, more or less at 23 gamma, together with low dose vitamin C IV.
That's a good question. I'm not too. I don't have any experience with ozone. I have experience with hyperbaric oxygen. I would think it would be a good idea, but I'm not sure. I think ozone may be a good idea if you can control it and not give it in a huge quantity, because you know it's for it to be converted to oxidative could be something pretty quick. With oxygen, you have
the dosage. That's why the recommended dosage is 23 gamma, to stay within that range and not do it daily. They've been doing rectal insufflation every other day, and they've been having very good response.
Okay, well, I think you have a point there. I mean, you know, we have to try anything that we can try to save those patients, man.
Actually, ozone, hyperbaric chamber oxygen, hydrogen peroxide, even with a nebulization or IV, they are probably more or less on the same pathway or mechanism.
Yeah, well, it's very important that you mentioned.
Question
Cheng,
for the.
it's important to dilute the hydrogen peroxide, even though you're using that 3%. But maybe you should go 50-50 at least, in order to get used to it and not to have a real big bad impact with it.
Can I ask a question?
Different question. Yeah. Okay.
This is obviously in Dr. Peng's study when the patients are on ventilators. This isn't possible, but I think obviously the intention is to have someone not get to that point. And as I understand it, ascorbic acid orally actually gets into the bloodstream faster. It's the form that we're most used to. And the work of Owen Fonerow has shown very rapid, I mean, literally within a minute, increases in ascorbic acid in the blood from oral ascorbic acid. So I'm just asking the group whether there isn't a merit in having very high oral ascorbic acid, for example, a drink every half hour, a gram every half hour. This obviously would have to be in patients before getting to the point of intubation.
Yeah, I think that's a great idea. That's probably the dynamic flow described by Steve Hickey. So yeah,
that's what I recommend. Yes,
that's
I don't know in Europe. Again, Dr. Alfaro from Puerto Rico. I don't know in Europe, but in the States and in Puerto Rico precisely, we have a very serious issue with leaky gut. So I don't know how those high doses of oral IV of oral vitamin C would be the outcome with the presence of leaky gut.
So Patrick, we have a protocol. Any COVID admitted to the floor gets high dose oral vitamin C together with oral vitamins. The idea is to try and prevent them progressing. It's only once they come to the ICU do we switch them to IV.
Dr. Merrick, what's your dose again? I forgot. I think you mentioned. What's the high dose of oral?
Yeah, so I think, we're doing like, depending on the practitioner, it's not massive doses. It's like 500 Q6, but we could go to a gram Q6.
Oh.
It's because we use a gram an hour anyway for people with flu, and generally the finding is that when someone is in a state of serious infection, they don't get the loose bowel, the bowel tolerance problem, which may be relevant to the the leaky gut issue. But I mean, just from the biology, the evolutionary biology, ascorbic acid, is what we are used to. And it's possible, obviously we cannot have intravenous ascorbic acid, it's too acidic, but it's possible that, that we may be seeing different effects from ascorbic acid. And, we obviously have to deliver that orally to sodium ascorbate.
Our experience is that the worse that you are, the more you're going to absorb without getting the diarrhea effect. Yeah. And the other thing is the form of ascorbic acid may be very important at this stage. And what our experience is that we favor the powder crystal form because it's very well diluted in water and it's distributed very well once it's taken. I mean,
yes, I have a couple of COVID-19 patients taking high doses of vitamin C by mouth, vitamin C powder. And they would go to 30 grams a day, 70 grams a day without any, loose bowel at all. And, so I recommend, I recommend hourly dose of vitamin C, a minimum of 1 gram, all the way to bowel tolerance or just sub-bowel tolerance levels. Oftentimes they can tolerate much higher than that.
We have a major problem in the UK. No one is taking vitamin C at all seriously. The general conception is simply, it's there to treat scurvy and, you just pee it out and it's a waste of time. So one thing that you mentioned, Richard, in the last webinar, which is fascinating and so brilliant, is that some of these COVID-19 patients in ICU are being measured with levels of ascorbate in plasma at the level that would diagnose them with scurvy. Yeah. And I thought that was a really important statement because in that context, one would immediately have the grounds in any event to treat the patient with vitamin C, literally to treat scurvy. So
I think that's a great point.
In those,
that's a really great point.
Yeah.
Can we find data on that? Because that's something that's really important to share.
There's plenty of data on that.
That's actually a good point. So I have a colleague in Detroit. They have a massive outbreak in Detroit. He's been trying to measure vitamin C. He tells me the levels are so low they're unmeasurable. So, I mean, but people are going to argue, well, so what? Do you have to correct it? But I think you're right. It does provide some kind of physiological basis on which to treat them.
Yeah. Well, I'm pulling it up. At the NIH, I gave this presentation a couple of days ago. Well, first of all, let me give you a few positive updates on that. The presentation at NIH was well received, and now it's caught some other people's attention. One of which is from the office of the Assistant Secretary of HHS at US, and so she has forwarded the PPT, my PPT, to FDA, and an FDA officer is now reviewing the data on this. So hopefully, the government will take a little bit more serious at this. Like I said, vitamin C, and even at a very high doses, is safe and is cheap and is readily available. We can't, there's no evidence whatsoever so far that will do any harm to the majority of these patients. So we should, like Dr. Fowler in one of his recent papers said, we should use compassionately. But now I'm going to address one of the person's question is about the vitamin C deficiency. Let me give you this in the PPT. So basically 40% of ICU patients with septic shock have blood VC levels approaching 0. That is diagnostic of scurvy, okay? And this is from a review in critical care by Carr et al. In 2017. I have all the reference if you need. And, Dr. Paul America is very familiar with this. And the remainder 50% of the 50% of the non-septic ICU patients have vitamin C deficiency, which is less than 23 micromole per liter. And also low plasma levels of vitamin C are associated with more severe organ failure and increased mortality. These are all well documented in the literature. And that's why a lot of people, we can't ignore these facts. I know these are the literature studies on other conditions, but COVID-19 is no different in that case, is that it's another pathogen. A lot of things are common. For example, the increased oxidative stress. That's a common mechanism. We shouldn't be treating every disease as an entirely 100% different entity. Yes, COVID-19 has its uniqueness. Like every person in this world, we're different. However, we're all humans. We have a lot of things in common. And all these diseases have a lot of things in common. At the biochemical level, let me tell you, I think it's all the same thing. It's fundamentally a redox reaction. The imbalance of the redox reaction, that's at the biochemical level. We have to treat at that level. So
can we ask Dr. Peng? Dr. Peng, did you measure the plasma ascorbate before the intravenous infusion?
No.
So we have a baseline.
No. We haven't measured it yet because this is the very complicated issue. We cannot collect sample, blood sample to bring out for the measurements. So we try, but it's difficult for us to measure samples.
It has to do with the contamination of the machine, as I heard. It would
probably
HPLC, But I think Kay Cheng mentioned to me maybe a couple of months ago, they have a simple method of deactivating the virus before they apply to the machine.
Dr. Cheng, to follow up on what you just said,
yes,
in those scenarios of sepsis and infection in the ICU, do you have any metrics, or do you think something similar would be happening with plasma levels of ALA or glutathione in addition to ascorbic acid?
I think so. Yes, I think so. I think the basically, if you look at I have been primarily interested in chronic diseases prevention and management. So I look at in the literature. I have yet to find a chronic disease where the studies have been done that the oxidative stress is not increased. So every chronic disease, if studies have been done, it is associated with increased oxidative stress. And I believe, that at the acute diseases, this is probably more significant. So antioxidant treatment is at the front line, you know, in these acute diseases, including right now the COVID-19.
Got it. That would be some interesting metrics to get as well.
If we can prevent
some plasma levels for this.
Yeah, if we can prevent COVID-19 patients from going into significantly increased oxidative stress and the resultant clinical ARDS or micro angiopathy, all these things, it will be just a common cold, you know, just common cold. And so I think that's early high dose vitamin C. That's and other antioxidants that will be necessarily needed.
Yeah, Richard, can I just add the other antioxidants